Testing. Everybody here okay? So I'm John Porter. I am Medical Director of the Comprehensive Pain Program and Director of the Osher Center for Integrative Health here at the University of Vermont. So we are delighted to spend some time with Dr. Shari Ling, who I'll introduce in a moment. But this offering is part of the endowed Laura Mann Integrative Health Lecture Series. Laura Mann was a nurse midwife who was diagnosed with stage 4 breast cancer. And at the time of her diagnosis, she took on the challenge of figuring out how to engage in a wide variety of integrative practices to optimize her health during her journey. In 2015, the Laura Mann Center for Integrative Health, which she started, merged with the University of Vermont Integrative Health. And then we have gone on to become the Osher Center. So I just want to make that acknowledgement for Laura Mann. And now we are thrilled to have Dr. Shari Ling with us from CMS. She is the Deputy Chief Medical Officer of CMS. And in that capacity, really has devoted her work life to figuring out how to get the best outcomes for the beneficiaries in a really complicated system. So her specific interests are on issues involving multiple chronic conditions, health disparities. She is a geriatrician. She's a rheumatologist. She describes herself as a recovering researcher, having spent 8 years at NIH. And she has come to Vermont to try to figure out what we're up to here in terms of the work that we're doing around chronic pain. So we're delighted that you're here, Dr. Ling, and I'll hand it over to you.
Oh. Is this what I use? I think. Yes, it is. All right, just checking sound. Am I good? Okay, thank you so much. And I'm really honored and delighted to be here with you all. Admittedly, a little last minute as far as could I actually travel. We did get the go-ahead yesterday at 5:30 in the morning, so here I am. And just to explain why I really wanted to be here with you in person, it is a unique opportunity when we're able to envision systems of care and interventions that actually hold promise to really meaningfully improving health outcomes for the people we serve. And when those bright spots are identified, there's always an opportunity to understand what the secret recipe is. And rarely is it just the recipe. It is the people who actually make it happen. And when you identify these bright spots, it ends up being about leadership. So, John, and all of you who have led these efforts, I'm here to say thank you, and to really understand how can we work together to go bigger, go faster, because I think we have enormous opportunity and need to solve important problems that have been vexing and have had stood in the way of health outcomes being optimized for the people who we serve. So with that, I am obliged to show my federal disclaimer that, the comments that I will share with you today, they are my own, and at the same time, really reflective, though, of some emerging programs and policies, and things change so quickly. I was explaining that I was listening to and reading the State of the Union address and just excited to see some opportunities there that I think really set a path forward for us. But to start, I think each of us comes to the job each day with a mission, a personal mission, a professional mission. But if we come together, each with our own individual roles and fulfilling our responsibilities, we can actually build a better system. that works for the people who we serve. So for all of you who are listening, what can each of us do to improve health outcomes for the people we serve? And eliminate the harm that arises through the course of medical care. Still, 1 in 3 individuals who are admitted to the hospital suffer an event that was not intended, and during the course of care. We have to be able to focus on health, and health is not just the absence of disease, but putting together the physical and cognitive, mental processes and factors to really acknowledge the people who we are serving, and to do so through engagement with care that is accountable, that is well coordinated, that is around the people who we serve. There are infrastructure needs, and I think of this as, this is not just the technical infrastructure, but the people who are part of the solution and the system, right? This is our workforce. Nothing will happen without an engaged and robust and resilient workforce. So that is people who are here now and the people who are coming through as our future. We have to focus on what does quality look like. And I was really interested, and I'm interested to know what we have operational definitions of quality. We have a strategy that I'll speak about. But on the ground, what does good quality care look like, and what is it going to take? How do we actually get there? And we know we get there because we have to rely on data and performance and evidence. We can conceptually conceive of what might work, but we actually need it to work. So that is the implementation, our own histories of what is working, but also what are the failures and why did good ideas fail? And then, of course, there's the opportunity to test new and innovative approaches that we can collectively scale, whether it's local scaling, regional scaling, or national scaling, and for us to really end each day with a renewed commitment to, this is what I learned, this is what I achieved, and I'm going to be ready for tomorrow. So I'll break down my remarks into 3 categories. One is to understand a little bit about, I'll focus on Medicare. We have our colleagues leading the Medicaid program here today, which I'm eternally grateful for you being here and for the work that you do. So you probably know more about Medicaid than I do, especially in the implementation. So I'm going to focus a lot on Medicare because of the dual nature of the population that we serve. And I will also try to impart share some content of some of the covered services that are available across Medicare and also Medicaid, and introduce to you the behavioral health strategy that CMS has put forward. So with the role of CMS, so I serve as the Deputy Chief Medical Officer for the agency, and CMS is an implementation agency, which means we follow the laws and are charged with implementing the laws that come before us. And so part of that charge, or largely that charge, is to provide access to and pay for care and services that meet the needs of our population. Our 3 M's is what we call Medicare, Medicaid, and also Marketplace, and following the strategic pillars of advancing equity, expanding access, engaging with partners like all of you, driving innovation, and doing so, but still protecting our program, that is program integrity, and fostering excellence as we go. So all in all, CMS touches upon the lives of about 1 in 3 Americans today, and remains the largest payer for healthcare services globally. And so the numbers are, really staggering. The dollars that pass through and are applied as payments for healthcare services, we really need to understand, how does that translate into the health outcomes that we come to work each day to try to achieve, right? So in order to do that, we really do need to understand the people who we serve. And this is just one example of some of the data that we utilize to understand the people who we serve. This is a snapshot of the fee-for-service beneficiary population. And just to, I think I'm going to get myself in trouble if I try to highlight on the screen with this. So I'll talk through it. So what appears here in the dark navy blue, it's a percentage of the Medicare population that has just that single condition, right? So we have a focus on behavioral health. So you can see on the left that 4% have a diagnosis of alcohol abuse disorder, and another 4% substance abuse disorder. And since we are focused on pain as a indicator, arthritis, 7% of the Medicare population. But as you move to the right, we increase the number of other comorbidities that the individuals, that the populations have. So what this means is that in the yellow, 1 to 2 other conditions, in the beige, 3 to 4, and in the teal on the far right, 5 or more other conditions, right? So you can see, from the perspective of patient care, this is complex. People's needs are complex and likely will cross between physical and mental health needs. And, as I spend my Mondays, I donate my time as what they call a walk in the VA. It's a without compensation. I'm a dementia care provider. And every single veteran we have seen over time has multiple conditions, including cognitive impairment, some of whom have significant diagnosis of major neurocognitive disorder, that is, AKA dementia, but they also have chronic pain, vascular disease, substance use disorders. So, mental and physical health needs are really converging in the people who we see. And yet, if we take a very specialty focused approach, we run the risk of ignoring the intersections, the needs of the people. But, check, service provided, we can do better than that. And I think we need to. So, just a few program facts about the populations that we serve. So both Medicare at the top and Medicaid and CHIP on the bottom. Over time, you can actually just get a feel for, the different domains or entitlements within Medicare. And you can see the general trend of increasing over time. So I know you all are sponsoring a geriatrics conference in April, which I was delighted to actually see it flash by in prep, because the patient's needs that you will have are very complex. And as a geriatrician still practicing, just value the and multidisciplinary, transdisciplinary conversations where we just do better in team-based care than as individuals. We are not islands, right? No person is an island. And what the patients who will be before us need is an integrated approach. So I think the opportunities really loom large and the challenges loom large, right? How do we do this in a system that is really still remains on a fee-for-service chassis. So these are what you see here. This is what I call my program and activity wheel. CMS has specific authorities that come to us by way of different pieces of legislation. The original Social Security Act, which actually I'll speak a little bit about, is built upon with other laws that come to us. The Affordable Care Act, the Support Act, the Impact Act, all of these say, CMS, thou shalt take actions in this way, whether it's quality or payment or about infrastructure. So, this is the structure through which we can translate what we learn of as evidence that is emerging about, how do we improve outcomes? But we have to be true to the bodies of the laws that we are expected to implement. So I'll touch a little bit on, payment. CMS is viewed as in our payer capacity, but also for purposes of coverage, and also moving towards value-based constructs that rely on quality, public reporting, and quality measurement, and our innovation, both in our innovation center through demonstrations, but the innovation that we have the authorities to implement through the different constructs in the Medicaid space, which you all know probably much better than I do. But I think there is opportunity for us to pull and braid and blend some of the authorities and ability to solve important problems. So Medicare, if you think about that, this was enacted in 1965. I'm looking at becoming a Medicare beneficiary next year. I was 5 years old when this, and to think about all that has happened scientifically over this time, right? We have new provider types that we didn't even conceive of in 1965. And, there are certain restrictions, though, that CMS has to abide by for payment purposes. And yet, and what I'm referring to is like certain provider types are prohibited from receiving direct payment. So pharmacists, completely different role that pharmacists play now in comparison to then. But, legislation, new laws have to be enacted to remove some of these restrictions. The Medicare parts, which I'll talk a little about, are defined benefit categories that we have to be respectful of, and also for all of you to know that Medicare does not include long-term coverage for long-term services and supports. I would love it to happen, but there are these things called laws that, so how do we get to provide care and services and cover care and services for people with chronic needs? Our framework really is based on acute care. And the compilation of acute care does not chronic care make. So, but these are the different benefit categories of Medicare, different parts. Part A, hospital payments, skilled nursing services, hospice care. Part B, doctor's visits, outpatient services, durable medical equipment, coverage and payment, physician administered drugs. And here physician is used, but really represents prescribers. So clinicians who have the authority to prescribe. Part C are health plans, and Part D, which is the prescription drug benefit. I neglected to also include some of the home health benefits that are really in the Part A space that have the ability to also elicit the services of home care and support under a clinician's prescription. And this is where the money goes. In Part A and Part B, you can see how what the focal point is, where the money power is, which is inpatient hospital services, physician, clinician services in the outpatient setting. And in Medicaid in particular, how much is really designated to managed care, plans, and also long-term care, right? But there is a gap between when one needs long-term services and supports as a Medicare beneficiary and translates into Medicaid. The waiting period is significant and challenging. And the good news is that the hospital-focused payments have, through the Affordable Care Act, and amended some of the Social Security Act requirements that include value-based purchasing, that includes quality measurement. And in order for quality measures to be considered for hospital value-based purchasing, those measures have to be displayed on the compare sites for a full 1 year before CMS can think about, implementing. So therefore, the compare sites, hospital compare, we call it compare sites now instead of hospital compare, because we have understood that care decisions on where people go for different care and services should not just be, predetermined by where a bed is available. So, hospital value-based purchasing, in addition to which the hospital readmissions reductions program has been added with different constructs of how the payments are redistributed, and also the lack of payment that will be provided if certain conditions arise in the hospital, amputation of the wrong limb, injurious falls, these kind of things that are preventable actually are important elements in these three payment adjustment vehicles: hospital value-based purchasing, readmission reduction program, and also the HAC reduction programs. So, I think it is an opportunity for us to look at these signals and say, what can we do better in the hospital to improve quality, to reduce harm that arises during the course of care, and also connect with our post-acute providers to enable care that will reduce the risk of being readmitted for the same conditions within 30 days. Now, Medicaid is a true and earnest program entitlement that really is about federal administration, but where states have the opportunity and authority to be the deciding body, so that the care needs that the state serves are best, that really are best met, right? So limiting federal overreach to say you must do this, that, or the other. But, also, though, we have the opportunity to communicate with our state partners about what the care needs are for us to learn, understand, and also be able to put in place necessary infrastructure to meet the needs of the beneficiaries. And these are some examples of Medicaid eligibility. And for Medicare, keep in mind, 80% are based on age, but also by way of disability and end-stage renal disease. Medicare is the largest payer for chronic kidney disease care, and a few additional specific diagnoses. So moving on to some of the key services and supports, just to put these two pieces together, we have Medicare on the left, Medicaid on the right. You can see that there is some alignment, but what I've tried to focus on in the Medicare space is some of the new care and payment codes that have been proposed and finalized through rulemaking, which really signal how important chronic disease management is to this population. We have new care management codes, chronic care management codes, complex chronic care management codes, cognitive assessment and management codes that include assessment of the caregiver. How are you doing? You know, what kind of struggles are you having? And also payment codes that cover collaboration between healthcare providers, which, you know, in past years it just wasn't acknowledged. It's just time that you take out of your day to call colleagues and work with colleagues to develop a care plan. So there are payment codes that are applied with a lot of focus on behavioral health conditions, which if you have a population of people with chronic pain, they're there. It's just a matter of, you know, being sure that the indications are aligned. But if you look, you will find. So I did want to mention the CMS Coverage Authority. Okay, again, as part of the Social Security Act, CMS Medicare specifically has the authority to pay for reasonable and necessary care and services or Medicare beneficiaries. So this is worded in the negative, which, you know, Medicare, no payment may be made under Part A or B for any expenses incurred for items or services that are not reasonable and necessary for the diagnosis, treatment of illness or injury, or to improve of the functioning of a malformed body part. I didn't write this. This is like, this is exactly what is stated, and it must align with the needs of the population. That is by the benefit category. So, you know, one of the major impediments, apologies, John, I'm going to say it again, which is, why do certain promising interventions, why are they not covered by Medicare? You know, when we review the evidence, the research, the number one reason is because if we want Medicare to provide coverage and therefore payment for services delivered to our beneficiaries, it's only proper that the people who are like the beneficiaries be represented in the science, in the studies, in the samples. And that really is a challenge that I would love to be able to rely on, you know, those of you who are in clinical science and implementation science to be able to provide the evidence that actually supports the application and translation of evidence into coverage policy over time. And this applies across provider types and across settings. And there are two mechanisms by which Medicare can cover. 80%, 90% are done by way of local coverage decisions. That is, the Medicare administrative contractors have the authority to evaluate the evidence and see if it's applicable to the population that they are charged with. These are geographically distributed. So the authority is local, but national, there are few, but nationally applicable coverage policies. And the authority for local is, as long as it does not contradict the national policy. If there's no national policy, local coverage policy reigns. And there are opportunities to cover during the course of evidence generation, that is, during the course of clinical trials and where the evidence might look promising but not sufficient. And Josh explained to me yesterday that some of the plans are starting to adopt this approach where we're monitoring the data, the outcomes, the implementation as coverage really is provided. But for us to be able to look at that evidence and then refine the coverage to really then result in either national non-coverage decision, national coverage decision, or then to say we will leave it to local contractor discretion, which resorts to the local. And importantly, again, to restate, so for on the right side is the therapeutics, the therapeutics, we need evidence that it actually improves meaningfully the outcomes for the people that receive the treatment. And for diagnostics, that incremental information is generated by a test, a diagnostic test, that then is used in the management of the patient. And this is important because if in our clinic, we're like, well, we could get that MRI, but what will we do with that information? The CT scan, the blood test. We should use that information that in the management of the patient. If you're not going to use it, then do you really need to get the test just because you want to know? So it's not an answer for me to make, but it's an answer that each of us actually we know asks ourselves each day in practice. Now, this slide just describes, in the context of drivers of change, we talked a little bit about payment. We've talked about coverage, right? Requirements for CMS to pay, but also quality, right? And there is a floor to quality that we call minimum health and safety standards that CMS has authority to promulgate, that are then surveyed to when the surveyors come into your facilities. They are looking for compliance with the conditions of coverage and participation that have been written and finalized through rulemaking by our CMS, our small but mighty CMS team. And if you think of minimum health and safety standards, then to apply on top of that, what does good quality look like, right? There's minimal quality and there's opportunities to raise up the floor, certainly, but to really stretch ourselves and our system to improve quality over time. And this is how we will define value. It is the intersection, the compilation of quality and cost. That's our operational definition. But then how do you measure quality and value? And operationally, we define this as care that is of the highest quality, which means it is safe, person-centered, results in the best outcomes, equitable, and also affordable. And those of you who have interest in our Innovation Center work, the Center for Medicare and Medicaid Innovation, CMMI, has the authority to support and implement and test care and payment models. But in order for those to scale, have to meet either there's quality and cost, either have to improve quality with cost being neutral, or reduce cost with quality being neutral, but preferably improve quality and reduce cost, right? And when we talk about quality, we're talking about what are the best outcomes for the people who we serve. There will be, and in our MIPS program, the merit-based incentive program, and in alternative payment models that we have been implementing over time, you know, there will be specialty specific value constructs that include quality reporting, quality improvement, and cost. But there will also be disease agnostic types of constructs. These are called MIPS value pathways. And each year, CMS has the opportunity to receive ideas about what would a MIPS value pathway look like, right? And this is again in the Medicare space, but acknowledging that, you know, many who receive these care and services are also, we have a blood bank shortage notice that I see here, but hopefully you don't, maybe on my way out of the building. So the national quality strategy is one that we have implemented, which specifies goals that will be very familiar to you because these are in alignment with the CMS strategy goals. And we have put forth a universal foundation of quality measurement, right? What we are trying to get at here is that there is no one right quality recipe for all clinician types, all providers, nor all patients. And to take a moment to understand how you as clinicians are assessed by way of quality. I was surprised. When I actually still participate at Johns Hopkins in their teaching sessions, and I asked, so how many of you are part of an ACO? Let's looking at each other. They didn't know, right? And okay, then how are you assessed? Geriatricians, how are you assessed for quality? They didn't know. Some of those decisions are made for them based on what the performance looks like best. So it could be that I, as a geriatrician, might be assigned a quality score, which is based on oxygen saturation checked in the emergency department. When in fact, I'm trying to keep people out of the emergency department. You know, no offense to those, you know, who run the emergency department, but really, if we can solve problems before it gets to that point, all the better. So, you know, we're trying to embed quality across the care journey. Just recognizing it, the same people go from clinic to, you know, acute care to subacute care to post-acute care to nursing home. This is a journey that people go through. And at each point, there's opportunity to improve quality and also focus on really what matters to the people we serve. And also recognizing that, you know, we are on a transition from paper measures to electronic measures to digital measures. We're trying to eliminate and reduce the burden that comes through quality reporting. We would much rather have clinicians face-to-face time with the people who they serve so they can understand who they are serving. So this is a CMS Measures inventory tool that you can access to look at the portfolio of quality measures that exist and know that this portfolio is expanding on the Impact Act authorities, which required standardization of important domains such as mobility function, self-care, cognition, goals of care, care planning. These are part of what we do day to day, but how do you actually measure it? So this work is being manifested in the USCDI uniform, United States something, which is the operational mechanism to talk about interoperability and information exchange over time and place, and that to look at the CMS data element library for some of the information on all of the domains that I've just mentioned. This has common roots with the Promise tool, by the way. So importantly, we're trying to fashion and enable these connections. So I'll spend the last few minutes on the CMS Behavioral Health Strategy. So this arose as part of HHS's need to address the overdose crisis. It was originally an opioid crisis that was a prescribed opioid crisis. But, you know, all of us who are clinical minds just recognize that it's not so simple, right? It's not about the dose. It's not about a prescription. It is something lies beneath the dynamics of what we saw. And lo and behold, over time, the crisis changed. The overdoses continue to rise, but the prescribed opioid-related events actually started to stabilize and go down. So in effort to really address that which is more foundational than the prescription, we work with CDC. They have backed off on their MME-focused guidelines, right? Which CMS actually implemented, monitoring and checks for, you know, are we exceeding, are providers exceeding this amount? There's no magic number. So, you know, we chose instead to focus on how do we actually identify the needs of the population and fashion care and services to meet those needs, focusing on three populations. So there's a population, people with substance use disorder, there's a population of people with mental health conditions, and there is a population of people with chronic pain, which is unusual in the usual construct of behavioral health. And I will say we also included people with cognitive impairment and dementia in this construct, although not depicted here, because we see this. And when we looked at our own data, we published several pieces of work across CDC, CMS, and NIH, and looked at overdoses, fatal overdoses. We looked at the impact of telehealth and the provision of MOUD to Medicare beneficiaries. And we saw certain trends. One of the characteristics we saw is that 80% of our population had chronic pain, of those who actually suffered an overdose. 44% had 2 or more mental health conditions. So when we look at the people's needs, it should be that there's no wrong door, right, to getting care that is needed. And it was very depressing that I think when we looked at it, about 8% of our population, after having an overdose, actually on follow-up was on MOUD. Huge need to improve there. And we didn't do much better when it came to naloxone prescribing, but naloxone can be received and met through many means. So we revisited and refashioned the strategy, and we have our new mission that we envision and hope and will drive towards ensuring high quality behavioral health care and services are accessible for beneficiaries and consumers. And that this care will be person-centered, right? As opposed, and as well as affordable, and optimizes health and wellness. And these are our functional domains, including coverage and access, quality of care and services, equity and engagement, and also meaningful use of data, the data that we collect and that others will collect. This is all summarized on the behavioral health webpage, which you can access, and we will keep this updated as our programs and policies evolve. But I did want to spend a little bit of time on this image. And this actually comes back to why I'm here. So this is an illustration, credit page that where our team, through our Office of Burden Reduction, interviewed hundreds of patients and clinicians to understand what was hard and uncomfortable and hurtful about how they interact with the healthcare system and what it is that they see as the impediments. And this includes the providers where, they're trying to discuss pain, but they're fearful of discussing pain because they don't know how to manage pain when in fact they're managing the person who has pain, right? The need to actually be able to juggle all of these situations, all of these conditions with quality of life, financial burden, isolation, all at risk. The person is on this tightrope. And what's being illustrated here is the punitive regulatory environment of this application of evidence and guidelines, which we actually heard and we've adjusted, we've refined. But on the right top here is the integrative care approaches, including interventional, including therapies that our health professional colleagues can administer, behavioral health care services, and providing mechanisms to provide care for coexisting conditions. So this is about physical and mental health integration, right? To meet the care needs. But we also acknowledge that, clinicians, often take matters into their own hands. And what we want is the flexibility to, when we find something that is working, I can tell you, right, why would we not think about how do we envelop things that we learn are working, that will work, that could work for certain individuals, that can be part of the, and this is what you all do here, which is an integrative approach where multiple clinical voices are part of the care team, and that there's community of people receiving care that learn together and heal together. And, this is something that we are very interested in and have taken steps towards. So, the opportunity areas that were identified from the pain management task force, we're taking these things to heart and really looking at ourselves and opportunities to improve. So one example of this was our national coverage decision for acupuncture for low back pain. And this is actually, details can be accessed by way of the Medicare Learning Network for guidance. This was very controversial, right? Because for two reasons. One is we restricted it to low back pain. CMS is a Medicare operational agency. So we needed evidence, and the evidence was strongest with chronic low back pain in the Medicare beneficiary population. And initially, we proposed this as coverage with evidence development. And our colleagues at the VA came through and said, can you look, we have some data on people of Medicare age. Can you use that? And the answer was, that would be enormously helpful. The construct here, though, is that, there are now 3 codes for acupuncture for low back pain. And the restrictions of who Medicare can pay, though, which is statutory, necessitated that we implement by way of incident two, that there is a responsible clinician, not saying that acupuncturists are not clinicians, but Medicare payable entity. So, and we are learning over time that the use of these codes, has started to rise, and the denials are declining, but not all systems utilize this code. So the question is, what is the difference here? What's the dynamic that supports use of this new opportunity versus non-use? And we can't see the dynamics, but for you to know, to ask yourselves, and how care flows and how payments flow, what keeps the current state the current state? So we also have proposed 2 chronic pain management codes. These are codes that can be used to buy a little extra time. There's no cap on how often or how many, but these are bundled elements, and these will sound very familiar to you because there must be a diagnosis of why is a person in pain. There must be assessment and monitoring of interventions that are implemented over time. We ask that there would be a tool that can be used. We didn't say which tool, but our colleagues at the National Institutes of Health stood up a web page to say, here are some validated tools, right, that you can use. It really focuses on what does each and every person need, and what have they tried, what has worked, what could work. And so, these are accompanied by resources, how to use the codes. I will also say, though, that there are other provisions in the Support Act that we have implemented on. I would keep my eye out for the 6086, the Todd Graham Pain Management Study, which actually called on CMS to look at evidence-based treatments and services and understand why are they not implemented, right? And so hence oh gosh, they forgot to include older adults in the study, but there are also other impediments that we are looking at to understand what will it take. But we've also inserted language into the Welcome to Medicare exam and the annual wellness visit that include, cognitive assessment, substance use screening, mental health assessment. All of this is really important. These are vehicles for coverage and payment that lend themselves to the opportunities to provide better care. We also have implemented Section 2005 of the Support Act, which is Medicare now can pay for opioid treatment program care. And to say that this is not just dispensing treatments, but it is also providing counseling, assessment. Interestingly, pain management is not part of this, but if we're thinking about the triad of painful conditions, mental health conditions, substance use disorder, this is a leg on the stool that is missing, but we did not have authority to include that. But it is worth thought about how would we create that bridge, right? And we'll also flag to you that this year we finalized several provisions in the physician fee schedule. We're thinking about more to come, but this includes, a ramp up on payments for psychotherapy crisis services, for psychotherapy services, enabling psychotherapy for periods of crisis, including new provider types that actually can directly receive payment from Medicare, including marriage and family therapists, mental health counselors, and also a new code called the PIN code, Principal Illness Navigation, which really is intended to support the evaluation and collaboration of care for people with complex conditions. These are just some examples of those type of complex conditions. But we're trying to really support clinicians in their provision of care. Again, recognizing that no person is an island. So again, this is where our behavioral health strategy lives, and with resources. And we have a CMS quality conference that is April 8th, 9th, and 10th. It's, I don't know where else they do this free conference. All you have to do is register, and you can participate by way of virtually. We include Tom Sandbrick and others for management how-to session as a breakout, and several sessions of managing complex people with complex behavioral health needs. And so just ending where I started, which is for us to, as you leave this event, for us to just recommit, right? And to ask ourselves, what can each of us do? What can I do to improve the care and services that we deliver to support and deliver to meeting healthcare needs of the people who we serve? And ending with tremendous thanks for all that you do each and every day to provide care to the people who we serve. So thank you so much.
We have a few minutes for any questions.
Thank you so much. That was fascinating. I wonder if you could sort of take us a little bit through the process of how Medicare decides to, pay for something new like acupuncture.
Oh, sure.
I would be fascinated to hear that.
Yes. So either we receive a request from someone, anyone, member of the public, or we actually have an idea because we've been tracking the literature to say, let's take a look at a treatment or service that looks promising, right? That the evidence is emerging, that could be helpful in the care and keeping of Medicare beneficiaries. And we consider that evidence. Sometimes when the evidence is voluminous, or that it's complex, where we have harm signals, helpful signals, if the evidence is mixed, we can convene what's called a MedCAC, which is Medicare Evidence Development Advisory Committee meeting, where we have subject matter experts opine on, the impact are the questions that are necessary for us to consider coverage answered. Is the evidence clear? Right? So first question, is the evidence sufficient? Second question, is the evidence clear? And then we go through a national process where we draft a analysis of the literature, a proposal to cover, and that goes through public comment. And whether it's coverage or payment or burden reduction efforts, including our recent prior authorization rules, it all goes through public comment. And our obligation is for each and every comment that is submitted by members of the public that we have to respond to. It gets challenging because some are just enormous in terms of how many, but that public comment is so important. Because if if comments are received that suggest an alternative that we did not think about, so, A, maybe A prime, or maybe B concept, if we have comments such as that, it gives us what we call logical outgrowth to finalize in a way that was not originally proposed. Without which, if the proposal is to be finalized, it will be finalized as proposed. So it is a public comment process, and it is a very, very public process. For local coverage decisions, something similar happens, but without the national scale of implementation. So it's a good question. And just to say, CMS processes, we are a complex organization. So, if those of you who are interested in policy development, we accept, we have a CMS Fellows Program. It's probably one of the best kept secrets that we have, but you could take on a project if you're a medical student, a resident, a fellow, an attending, someone who may be retiring at some point. There's no rule on, and health services researchers come to us to take on a project. So I think there's opportunity there, and every day I learn something new about how CMS works. So Josh, please. Yeah.
Hi guys. So thank you so much for being here. First of all, you're really like-minded. I think you really resonate with your approach. I had two very specific questions, one specific and one more broad. The first is there some discussion, so we're talking a lot about codes, about coverage for medical group or shared medical appointments? There is coverage for psychological or mental health group visits, but not for medical group visits for chronic conditions, and there's emerging evidence around that. My second question has to do with Medicare as kind of the national chief influencer of policy, and specifically around Medicare Part C, Medicare Advantage, and the health exchange. And if you could comment on how policies and the quality work that you do influences those coverage populations, because I think there's a connection, but there's an increasing number of people in the state of Vermont who are on Medicare Advantage, for example, and so we want them to be kind of
absolutely part of this. Yes. So I'll answer that first, which is, all of our proposals actually are decided upon by the CMS administrator. There's many parallels. There are limits to what CMS can require of plans. It is, and we also acknowledge the growth of managed care across the country with like 90% penetration in some areas. So we are really interested in how do we enable, the quality to permeate. So the quality measure development process, those quality measures that are selected for plans, there is a specific entity that is, the major contractor for that development and discussion, and but still it all has to align with the CMS quality strategy. So it's more at a theoretic level, and some devil is in the details, but I think the principles are aligned, the signals are strong of what we are looking for. So I think it's work in progress, though. But it's an important alignment to have. Now, repeat for me what your first question was.
Coverage for medical group visit or shared medical
Good
appointment.
question. Yes. So we were able to do this for mental health conditions, right? We are thinking about other applications. So the process there would be, you know, we're just formulating, just thinking about where we are in our rulemaking process. We could receive comments on proposals that with new suggestions, such as coverage for, but details will matter. Who are we talking about? Like what kind of conditions? You know, and those comments actually could be very helpful, especially when accompanied with data for and we can feed that into our rulemaking process. But I think we've made major strides towards being able to not be one, but more synthetic. But I like the idea. And I'm really glad to have seen how you have concocted the recipe here. Thank you.
Right. Thank you. We're over the 9 o'clock hour.
Thank you all for joining. Really appreciate it.